Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, thanks for joining in for this week's episode of the Healing Pain Podcast. Today we have a really interesting and of course important topic. We are discussing how to use pain neuroscience education to treat PTSD and chronic pain in soldiers and veterans. My expert guest this week is Major Timothy Benedict. He is a physical therapist assigned to the Army Public Health Center in Aberdeen, Maryland. He's the Deputy Chief for the Advanced Analytics and Data Stewardship Division in the Clinical Public Health and Epidemiology Directorate and assists with field investigations for the Injury Prevention Program. As part of Major Benedict's PhD studies, he developed a military-specific pain neuroscience education intervention for soldiers and veterans, and also completed a randomized controlled trial examining pain neuroscience education for soldiers with chronic low back pain and post-traumatic stress. On today's episode, you'll learn all about the link between post-traumatic stress and chronic pain, how to explain the link between PTSD and pain to your patients, the evidence supporting pain neuroscience education for individuals with pain and PTSD, how understanding the neuroscience of pain can help you build compassion and empathy for your patients, and how this research applies to civilians such as firemen and police officers. Now, if you've been following along with the Healing Pain Podcast, you know that I often ask our guests to provide some type of free download, a quick PDF cheat sheet, or maybe something you can use in the clinic. This week, Major Benedict has gone above and beyond any guest that's ever appeared on the Healing Pain Podcast. He has provided you with a complete 44-page treatment manual on how to use pain neuroscience education with soldiers and veterans. This manual is complete with full color illustrations, metaphors, and language that is specific for this population. If you're a practitioner and you're someone who uses pain neuroscience education with this particular population of clients or patients, soldiers, veterans, military, police, anyone in that realm, you're going to really love getting your hands on this. It's absolutely free for you to download. All you have to do is text the word 170 download to the number 44222. That's 170 download to the number 44222. Or you can open up a new browser on your computer and you can type in the URL www.integrativepainscienceinstitute.com/170 download. That's integrativepainscienceinstitute.com/170 download, and I'll send it right to your inbox for free. Okay, let's begin with Major Timothy Benedict and learn about a pain neuroscience approach to treat PTSD and pain. Hey, Tim, welcome to the Healing Pain Podcast this week. It's great to have you here.
Yeah, thanks, Joe. I'm definitely honored to be here and looking forward to talking with you.
Well, I came across a study of yours a couple of months ago, which we'll, of course, talk about today, but a lot of your work centers around kind of the links and associations between post-traumatic stress and pain, specifically in soldiers, which is a super important topic nowadays. A lot of the work that's being done, both in the world of physical therapy, as well as in the world of psychology, is really looking to help support our soldiers and help them cope with many things that have happened in the past to them or currently that's happening to them. Just give us, obviously you're a physical therapist, you also have a PhD. Give us a little bit of background, kind of, a little bit about your bio, and give us an idea of how you kind of wound up where you are today and where you're working and the great things that you're working on.
Yeah, all right. Well, thanks again. Thank you. And so I joined the military in 2002. I was an infantry officer and pretty much right away deployed to Iraq for a year. Got back, spent a year in Italy where I was stationed with my wife, and then immediately went to Afghanistan for another year. So it was pretty busy time of life. And it was during that second deployment that I applied to the physical therapy program through the Army, so the Army Baylor program. And so when I got back from my second deployment, went to PT school through the Army, got stationed in beautiful Hawaii, where I had another combat deployment to Afghanistan. And once we got back from that deployment is when I started to apply for a PhD program, which I was very fortunate. The Army sent me to the University of Kentucky to study for 3 years, and completed my PhD studying pain neuroscience education, which again, I think we'll talk in a little bit about why I particularly wanted to study the link between pain and stress, or pain and PTSD.
Hmm. And just tell us where you are today, where you're working today, and what your work looks like and what that centers around.
Right now, I'm at the Army Public Health Center. That's in Aberdeen Proving Grounds, Maryland. And I'm currently working on injury prevention, studying the link between soldier confidence and injury, and other types of programs where we can get to that construct of self-efficacy, confidence, and how that impacts a soldier's ability to do their job, to remain injury-free, to be resilient enough to remain a soldier.
Excellent. So, of course, I just want to start out and say, thank you to you and your family for your time and your service to all of us. We really appreciate it. It's important, I think, that we recognize that. And then just kind of moving on to back to the world of PT, why post-traumatic stress? How did that start to interest you, and why focus on that?
Yeah, great question. And so, as a young PT early in my career, I just started to notice this subpopulation of patients that came to me who had PTSD, and it just seemed that no matter what I threw at their tissues, no matter what I would do or what I applied from learning to PT school, I just felt like I couldn't make any type of difference. And I was like, man, these folks, they really need more than just addressing the physical tissues. And so I became frustrated because I didn't feel that I was personally able to help them the way that I wanted to. And so I knew a lot of us recognized that they did need help and treatments from on the mental health side of the military. But with that, of course, came a lot of stigma. There's a lot of skepticism then when any provider tries to talk about the mental health component of their pain aspect, because of course, our patients are coming to us with real physical symptoms, real pain, and they get pretty frustrated when no one can explain why they're having those symptoms. And so I really wanted to try to bridge that gap to help them see the things that we as physical therapy can do, but then also to give them buy-in for why the treatments that address the psychosocial aspect of their whole health and body really apply and could help them with their problems.
Mm. It's interesting. As we're talking, I'm reflecting back on my education as a physical therapist. I really can't think about in traditional in a PT curricula. I really can't think back and remember if I received any kind of trauma-informed education as a physical therapist, which is interesting because mental health providers oftentimes receive trauma-informed education. It's either part of their schooling or they can take a continuing education course. But I think as PTs, and maybe it was different because you were trained in the military, did you get a little bit of that in the PT program that you attended, or was it just something you started to notice at work and then obviously, do research on it?
Yeah, just completely from clinical experience. Unfortunately, and as you mentioned, just the importance of that entry level clinical education. I had never even heard of pain neuroscience education during my entry level program. So it's a gap. I imagine that as we learn more and more about the neuroscience of pain and how important that is even for entry level PTs, that just as you mentioned, that the trauma aspect of that, which is super important, very relevant for chronic pain, period, let alone PTSD. I think that'll become more mainstream and we'll get more education on that.
Yeah. How do you explain the link between PTSD and pain to your patient or someone obviously who has pain?
Right. So I think there's two important parts of this conversation. And number one is just to validate the patient's symptoms. And so a story that I share with really any patient who I'm trying to explain this link between pain and stress, it's a fascinating history story. So we just observed the 78th anniversary of the Pearl Harbor attacks, December 7th. And so it's an amazing story. On the morning of the Pearl Harbor attack, so December 7th, 1941. You had this Army private, George Elliott. He's up on the North Shore of Oahu. He's looking at his radar screen. And around 7 a.m., his screen, lights up. And so he says, hey, see some aircraft here. He calls up the higher headquarters. What should we do about this? Well, some lieutenant, Army lieutenant, he's on the, up on the watch. He says, I think those are just American planes coming back, returning from a flight. So he essentially said, just don't worry about it, forget about it. And of course, anyone who's read history, seen the movie, understands Pearl Harbor. Major disaster to ignore that radar screen on Pearl Harbor. So what I ask my patients then, do you think that this radar operator is ever going to ignore his radar screen again? And of course not. In fact, he's going to be extra hypervigilant. He's going to, the smallest thing that moves on his screen, he's going to call up higher hecklers, and he's not going to take no, or he's not going to ignore that radar again. And so from that point, we can really just validate the fact that, hey, when you've had trauma, when you've had a major injury, your nervous system is just like that radar. And after those events, to protect yourself, it's not going to be easy to just ignore these danger warnings anymore. And so that's the first thing that we can do to just validate the symptoms. Hey, you have real symptoms, and we can explain why it makes perfect sense that your body would adapt in a way to give you some extra protection after you've experienced either the trauma or the injury.
So you give them a really good metaphor that obviously starts to tell a story. It's a context that they can relate to directly, of course.
Right.
And I'm just curious because you mentioned earlier on that some people with PTSD feel like if they were to go for treatment with a mental health provider, which we know can be effective, and I, of course, encourage people to do that, but there's some stigma attached to that.
Yeah.
Have you experienced that the pain neuroscience approach doesn't carry that same stigma, and have people been potentially more open and interested in that approach?
Yeah, absolutely. It's a great conversation starter. And so, you mentioned that the article that, or you may have mentioned it earlier, an article that I wrote that introduces pain neuroscience education to individuals who have PTSD and pain. And we did have one group where when you just throw education at them, it can still be met with, hey, we need to have a deeper conversation one-on-one to explain the neuroscience of this. So it's definitely not a slam dunk, but it's a conversation starter, and it really gets the wheels turning and helps these patients to understand the link between the two. And so what I try to do is explain the neuroscience of stress, because, hey, everybody understands stress, especially soldiers and veterans, but everyone gets stress. And so to go further into the story of George Elliott in Pearl Harbor, we have an amazing gift of the stress response, this fight or flight response, okay? Because several lives were saved. We can all appreciate the fact that these soldiers who were being attacked on Pearl Harbor, they needed to have the energy, they needed to get that heart rate racing, that focus, the ability to mobilize those fight or flight muscles and run for cover and return fire to save their lives. So we can certainly understand the stress response and the usefulness of that during a crisis. The problem occurs, though, when this crisis goes on and on and on with no rest. So again, thinking about George Elliott there and his radar screen, he's going to be extra focused for the remainder of his shift that day, and probably a couple days, he's going to have enough adrenaline, enough cortisol flowing through him to stay focused. But can you imagine if he's on the screen 24/7, week after week, day after day? Eventually, he's gonna tap out. He's not going to be able to maintain that vigilance. And the same thing when we measure stress hormones in individuals who have had PTSD, who have had chronic symptoms for several months, several years. What we see then is these helpful stress hormones, so cortisol, starts to crash. It's like running out of ammunition.
Mm.
Cortisol is a hugely, it's an anti-inflammatory, anti-nociceptive drug that the body produces. But when it's been going on for too long in acute and chronic cases, it's no longer able to provide that anti-inflammation. And so then that's where a lot of these chronic problems, people not sleeping well, chronic pain, digestive issues, many, many things, depression that come along with having stress for too long.
Mm. I'd love for you to talk about that paper that you did, and I believe it was part of your PhD, which is great information. So I'd like you to kind of just walk us through what the aim of that paper was and some of the things that you created from that. And we're giving them away today for free. Tim's been really generous. They're great guides on PTSD and pain neuroscience education that any practitioner really should have their hands on if you're working with this population. But I guess first tell us, is there some research supporting PNE, pain neuroscience education for PTSD? And then tell us about your work specifically.
Yeah, so of course I had this idea that it just made perfect sense to me. I have a link between chronic pain and PTSD. So just to get a diagnosis of PTSD, there's a few clusters. So number one, after you've had a trauma, you start to re-experience this trauma. Okay, number two, you're hypervigilant. Number three, you avoid things that remind you of that trauma. And then it's very common that you have comorbid negative cognitions like depression, feelings of remorse, guilt. And so when I look at that cluster there, we see a lot of things in chronic pain as well. So we know people in chronic pain, they avoid, they re-experience spontaneous pain even after tissues should have healed. They can be hypervigilant, have central sensitization. So definitely to me, it seemed like there was a pretty close conceptual link between those two issues. And so I wanted to first make sure that as I talk about the neuroscience of stress and pain, that veterans, that individuals who have PTSD would be able to understand it, would be able to comprehend it. And so there's lots of other studies that have looked at the same type of issue. Hey, let's make sure that the end user, the patient, can understand pain neuroscience. And of course, just like what Mosley has found, just like other practitioners have found, patients do a much better job than what we as clinicians typically give them credit for. And so the first aim was making sure that these veterans could understand it, and then that using the military stories, like when I talk about Pearl Harbor, would connect with these veterans and would actually help them understand what's going on with PTSD and with stress. That was the main aim, first of all, before going out and launching it in a clinical trial. Mm-hmm. Can these veterans understand it? Does it connect with them? And that's what the first study, just pilot study with a sample of several individuals, both with and without PTSD, and found that they had really good comprehension, equal to a medical expert panel once we controlled for years of education. And so we met our first goals of making sure that our end user would be able to comprehend these materials.
Excellent. I mean, it's tremendous work. And I know specifically in the field of PT, there's really not too many people looking into PTSD and pain neuroscience education in that population, right?
Yeah, it's definitely new. I've met a few individuals at CSM Combined Sections meeting who are looking into it. But to my knowledge, that this was the first curriculum specifically developed for PTSD. And then you asked about my other research. So the next part then was testing it in a clinical trial. And what we found, we did a randomized control trial within the VA as well as with some active duty soldiers. And so we used the materials that we developed from this book, the PTSD and neuroscience education, and compared that to what we called traditional education, standard of care education. And that was all pulled from the National PTSD Center. Mm-hmm. So we were giving very solid evidence-based recommendations as the control education. So they were receiving things like mindfulness. They were getting relaxation techniques, breathing techniques, exercise guidance, all the things that we would typically give. Of course, the main difference being is that the pain neuroscience education got the why. Hey, here's why these things are going to work. Because you need to understand how these things affect your stress system, which will then affect the neuroscience, the neurobiology of the pain that you're experiencing. And so that, I think, was the critical missing link. And I was just amazed to see how just that small difference really made a big difference in how our patients in the experimental group, they had increased pain self-efficacy. They had increased pain pressure thresholds. So we found an objective improvement in their ability to tolerate pressure thresholds. They had increased control over their pain, and then decreased beliefs that pain is a sign of harm and damage. So a lot of good things we found. A very small clinical trial, 14 in the experimental group, 18 in the control group. But I was very happy to see that this was a successful program with them.
Yeah, and of course you held up your book there, and I have copies and you're sharing it with everyone, but there's some wonderful pictures in there and stories and metaphors, and of course instructions and help for practitioners who are working with people who have PTSD and obviously chronic pain. So obviously we have large scale meta-analysis on explain pain neuroscience education. You now have, even though it's small, but it is a randomized control trial that shows it specifically works in the population you're working with. I'm wondering what you would say to a physical therapist who right now, or any other practitioner outside of the mental health realm, maybe an OT, a PT, maybe even a massage therapist, who might be saying to themselves, well, this is really all interesting. It sounds really interesting, but I don't necessarily feel that treating PTSD is in my scope, or I don't feel like I have the skills, or I'm not really sure if this is a place I should start to, weed into, basically.
Yeah, that's a good question. The really cool thing about PTSD and pain is that what the research shows is if you successfully treat the PTSD in a mental health setting, psychological setting, their pain improves. Conversely, when you take individuals that have comorbid PTSD and pain, and you just address their pain, their PTSD symptoms improve. And so I'm definitely, not encouraging anyone to go outside of their comfort or their lane of expertise. But all of us have a great opportunity to affect these individuals' mental health symptoms as well as their pain. So certainly, I don't think you have to be an expert in pain neuroscience education or an expert in PTSD. You can stay in your lane and do a great job of treating those nociceptive inputs, give a great exercise prescription program, a great treatment program. Obviously, I think that, and what our research shows is if you apply this treatment within the context of pain neuroscience education language or psychologically informed treatment, I think it will be more optimal than just applying a biomechanical approach to these treatments. But I don't think you have to go into a full discourse of pulling out the book and doing a walk line by line P&E approach if you're not yet fully familiar with these types of concepts.
Right. It's kind of interesting for physical therapists to think that what they're doing can have a dramatic impact on mental health.
Yeah, absolutely.
Because if you go to any, let's say, DPT program website and you look at, what they're listing, a lot of it's around orthopedics and sports and physical function, but rarely do you ever see anything about, hey, what we do as physical therapists could in fact impact mental health as much as, or potentially even more so than, let's say, psychotherapy for some people.
Yeah, absolutely. It really does just open up the doors, and we're talking about the whole person here. And so to think that you're just having a joint walk into your clinic, or a few muscles come into your clinic, you can treat that all day. But if you're not taking that whole person, if you're not addressing the mind, the spirit, their social environment, we're just not going to be as effective as if we understand how all of these things affect their brain, the way that all these nerves are connecting and firing, ultimately affecting their pain experience, affecting the way that they feel about themselves. And so we've got great tools, and we are an incredible profession to lead this way and to really help bridge that gap between the physical and what a lot of times is just considered a mental health condition. We can really validate these things and bring a lot to the table as PTs.
Yeah, as we're talking, I almost wonder if PTSD should be labeled a mental health condition, and if that would maybe just help people a lot right there. Those are of course, big topics, probably for another podcast, but
Right.
you and
Yeah.
I are probably on this similar page with regard to that. So, with regard to your study, that RCT on P&E and PTSD, was it a lot of the P&E studies are either a 1 or 2 hour class or a 1 to 2 hour intervention with P&E. Was that how your RCT was set up as well?
So probably total contact time was similar, but what we did is we did 4 sessions once a week for 4 weeks, and each session lasted about 30 minutes, where we would do the education at the beginning, followed by our exercise program.
Mm-hmm.
So it was actually shorter. I think that they were able to, tolerate it a little bit better in terms of just attention span. So we're not sitting there for 1 to 2 hours. But then we could reinforce it by the following week and the following week. So 4 sessions total, about 30 minutes in length for each one.
30. I'm sorry, you said 30 minutes in length of each one times 4 sessions?
Yes, yep. Once a week for 4 weeks.
Which is totally doable for the vast majority of physical therapists in private
Yeah, exactly.
practice, right?
I felt like that kind of fit what was probably reasonable, both in military as well as civilian practice, of getting that patient in and spending that one-on-one time with them once a week.
Yeah, exactly. How does understanding pain neuroscience and stress help us take a more compassionate approach to our patients?
Yeah, so going back to what I said before about validating their symptoms. So first of all, just by being able to validate those symptoms, I think that we can really get a lot of buy-in and help our patients understand that we get what they're going through. We can explain it, and that's hugely rewarding for a patient to have someone who gets what they're going through. Research shows us over and over again that adverse childhood events, so childhood trauma, has a number of negative health effects later on in adults' lives. So whether you're talking about PTSD, you're talking about chronic pain, obesity, you name it, a lot of this probably had some root in childhood. And so it's interesting. I'm a parent of four daughters. We have 2 biological kids and 2 adopted kids from China. And so those 2 kids, they have a history of trauma. And it's opened up my eyes, despite what the research has. What the research says, when you experience personally, it really just opens up your eyes to what trauma does. We've almost got like a case control series of our 2 kids who are normally attached and wonderful biological kids, and then when you have 2 kids who've had trauma. And so just one, my wife and we're amazed, we're surprised. And when they get an owie, it's over and over again. Mommy, I got this owie. I got this owie. So just this constant seeking for comfort, right?
Mm-hmm.
And it just kind of opened up my eyes that a lot of adults that we're dealing with, it's just like our kids who've had this trauma. They're just looking for a way to put all the pieces together. They're looking for help, really. And so I think that as a clinician, we can recognize that when you have that patient who's seeking care, and a lot of times we just want to minimize it, try to reassure that patient, oh, your knee joint is fine, your back, no red flags. You just think you're okay. We're kind of saying get over it. And same thing with my kids. We want to minimize it. Oh, you don't need a Band-Aid. But what we realize is, hey, they have a real need that they're communicating. How can we help them? How can we put a Band-Aid on them? And then provide a safe context where they can grow. And it's the same thing with our patients. We can be part of their story where we finally because that's what trauma is. These patients didn't have control, and some just, a terrible life event occurred to them. So now we can start to explain their symptoms as well as give them control, give them areas that they can control their body and get some influence over their stress system to eventually help them.
Yeah, beautifully said. And thanks for the example of your children. That's important for a lot of people. Will be able to relate to that. So we talked about pain neuroscience education. We talked about pain, PTSD, a little bit of your research. Of course, all pain neuroscience education within the realm of physical therapy is a form of PIPT, or psychologically informed physical therapy, part of a good biopsychosocial model of care. Early on in the podcast, you mentioned the topic of spirituality, which comes up rarely on the podcast, but people do kind of, mention that. I would think that's probably an important topic for some of the patients that you're seeing. Can you talk about how that may inform your practice and your care, either from a personal perspective or the perspective of your patients and clients? And I'll just kind of preface, I did a little bit of research as I was, looking at your awesome work, and I was reading your dissertation action. You actually touch on that really in a subtle but effective way, actually, in your research, with taking some scripture and relating it to neuroplasticity, which I think was really interesting.
Yeah, so sure, I'd love to share. It's just fascinating to me, that some of the things that we identify as neuroplasticity. So in the Bible, it says, be transformed by the renewing of your mind. That's just one example. Another example that's commonly used within medical providers is meditation and mindfulness. And so these are practices that I have personally practiced through my faith as a Christian. But for a while, I was like, oh, I gotta make this divide. When we're working with bodies, we're in a clinic. I didn't feel that there was a role necessarily for bringing in faith discussions. But then as we start talking about mindfulness and other types of religious practices, you really see that these practices, we can measure it through functional MRI. It's not just a mindset. We're making real changes here. And so I certainly, just from both a personal as well as a holistic clinical approach, I believe that that approaching people through compassion and through love, and equipping them to be able to realize that their problems are a lot more than just their physical tissues, and the solutions are much more than just the physical solutions that we get. And so this has really opened up my eyes, and I feel freed me, as well as just our profession, to address deeper things than just the body.
Yeah, so important. Thank you for saying that. Of course, people who listen to this podcast know that we're talking about deeper things on a biopsychosocial level, but bringing that topic into, our spectrum of scope of practice, if you're a practitioner, or obviously if you're someone with pain, to start to think about those avenues. So Tim, tell us what's next for you. I mean, you've done some awesome work. You work at an amazing place, helping people. What's new for you in 2020 into 2021?
Yeah, so it's pretty interesting. The Army's going through a pretty significant transformation right now. So they're every year we have to do a physical assessment test, push-ups, sit-ups, 2-mile run. Now this is going to a 6th event test, and it's supposed to be much more combat focused. So they're going to include a deadlift, throw in a medicine ball to assess power. It's almost like an obstacle course where you have to sprint down and back carrying a heavy load. So much more difficult. And as you can imagine, for a lot of soldiers, it's stressful. It's stressful with this big change, because people are concerned, okay, how am I going to train for this? Am I going to get hurt doing these new events? So that's the main thing that we're evaluating. And of course, linking that to my research, what I know and what we have found through these studies is that the more anxiety you have, the more likely you're going to get injured, the more likely that you're going to have chronic symptoms. It's really quite fascinating just to to see the hormones, that your body releases when you're having high levels of stress, high levels of anxiety. And what that does, it increases the pro-nociceptive signaling. And so there's this big link between individuals who have that high anxiety, low confidence. They're unfortunately more likely then to get hurt and to stay chronically injured or chronically disabled. So that's the main thing that we're looking at. How can we bridge that gap, make soldiers more confident as we transition to this new combat test?
Awesome. Of course, awesome work as well. If you get that study done and published, please come back and talk to us about it. We'd love to hear about it. This is a platform for you as well to, share your work and help inform people, and of course, inform the care of both pain and PTSD and the other things you're working on. Tell us how people can learn more about you. So if someone wants to contact you and learn more about you, how can they contact you?
Yeah, well, we'll make sure my email address is loaded into your website there. That's the main way. So I don't have a personal website, but the books that you can download really have all of the up-to-date information that I've put into in terms of pain neuroscience education for both soldiers and veterans, which I think that a lot of this applies to civilians. But of course, there's a high veteran population that we're likely seeing as clinicians on the civilian side as well. So I think that these materials can hopefully be useful and applicable to individuals with or without military experience.
Absolutely, definitely applicable. Of course, I want to thank Tim for joining this week and talking about PTSD, chronic pain, and pain neuroscience education. All three are important topics, and when you put them together, it's a super important topic, of course, for practitioners as well as people with chronic pain. Make sure you take this link and you share it on your Facebook page, on Twitter, on LinkedIn. If you know populations where people are struggling with pain and or PTSD, no matter what the cause, make sure to share with them. It's important information. And of course, make sure to download that free ebook. If you're a practitioner, you're going to love what you see in there. Again, I want to thank Tim for joining this week. I'm Dr. Joe Tatta, and we'll see you next week.
All right. Thanks, Joe. God bless.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.